to New Retina Radio, and this is something that I've really been looking forward to. It's the New Retina Radio Journal Club, and I'm joined by Jorge Fortun. Hello, Jorge, and welcome to New Retina Radio. Tell us a little bit about New Retina Radio Journal Club.
We're excited as members of VBS to partner up with New Retina Radio to launch this new series called New Retina Radio Journal Club. And as the name implies, it is a journal club. But as you know, VBS, Vit Buccal Society, which is a group that was founded by young, innovative retinal surgeons, now has grown over the years to include members from across the world. We like to be slightly innovative. And while there's parts of the journal club that will be more familiar to our listeners from their training, where we review some of the latest papers, we really try to focus on papers that are clinically applicable to your practice. And so while we go through the data, we'd like to have a collegial discussion among several co-panelists, which is very much in the spirit of VBS, so that what you take away from it is not only the top line data, but really what do these papers mean to our day-to-day practice and how we think about our patients and how we think about future directions in research. So it's really more of an informal journal club. We try to not get so much into the nitty-gritty and really have a good group discussion in a way that's easily digestible for our listeners and reviewers.
Fantastic. Jorge, tell me a little bit more about the Vit Buccal Society and the meetings that Vit Buccal Society has, your involvement with Vit Buccal Society, Marinelli, your co-host's involvement with Vit Buccal Society.
Yeah, well, John, as you know, because you were one of the early and original members, Vit Buccal Society was started, I want to say close to a decade ago now, by a group of young vitreoretinal surgeons that wanted to establish a setting where they could discuss surgical issues in a very open and collegial setting. And we started off early on. I joined because of knowing Tom Albini and Ross Lackenpaw when they were at Baylor. So I came along a little bit later. But when you guys started this, you started having meetings in conjunction with other national meetings, and there would be dinners at first. And then we started launching our own standalone meetings. And each year it's gotten better and better, and the participation has grown more and more. And we've continued to branch out into other areas. And Marinelli, who is the other person really responsible for putting together New Retina Radio Journal Club, has been so instrumental in that. As a younger generation has taken over, we've not only branched out from the meetings, but really VBS seeks to get involved now in other educational platforms, including this platform right here, which allows us to reach such a wide audience.
You know, there's no doubt, Jorge, that New Retina Radio will be a great platform for you guys, that Marinelli is involved. It's going to be organized. And if you're involved, it's going to be funny and fun.
Yeah, we're hoping to put the FUN back in Journal Club. I am joined today by membership from the Vit Buccal Society. For those of you who don't know, the Vit Buccal Society is an organization that was originally founded around young vitreoretinal surgeons, but clearly we all do more than just operate, and we're here to show that we're pretty well versed in medical retina as well. Today we'll be talking about a medical retina topic, and particularly we'll be talking about macular degeneration, neovascular macular degeneration, and geographic atrophy, what the role or lack thereof that anti-VEGF treatment plays in it. I am honored, and it is my pleasure today to be joined by three Vit Buccal Society members, Cynthia Qian, Christina Weng, and Basil Williams. Before we get into a larger group discussion, Cynthia, let's talk a little bit about these two papers, the first of which is the incidence of macular atrophy after untreated neovascular age-related macular degeneration, which is a study that was based on the AREDS group, looking at patients that developed geographic atrophy in the absence of anti-VEGF treatment, which is a pretty unique study population. And then the second paper, which is the spectral domain OCT-based prevalence and progression of macular atrophy in the Harbor study. So clearly a different patient population, patients that were treated with anti-VEGF. Not only that, but analyzing geographic atrophy using more modern technology in spectral domain OCT, as well as more updated treatment parameters. So with that, Cynthia, I'll just kick it to you so that you can summarize these papers for our listeners and our viewers before we dive into a deeper discussion.
Yeah, great. And thanks for the introduction, Jorge. So I'm really looking forward to today's discussion with my co-discussants about these two topics. So the first one, as you mentioned, is the ARIDS report number 40, which came out in the Blue Journal a little bit earlier this year with authors Christina Qian et al. And as you mentioned, Jorge, this is a very particular cohort of patients that's really hard to come by, because these are patients that were followed who were untreated, who were basically entered the study between 1992 and 2000 and followed until 2005, who did not receive anti-VEGF therapy at the time of their follow-up. And basically what we're looking at here is the incidence of macular atrophy, so specifically different from general geographic atrophy, but macular atrophy that arises from the natural history subsequent to untreated neovascular AMD. So what they looked at is of the total population of ARIDS participants, 708 eyes of 627 participants were identified to demonstrate neovascular AMD, and they became eligible for the study and follow-up. And the study used Kaplan-Meier survival curves basically to demonstrate the data, which was also stratified. And what they looked at was how and whether there was difference in the incidence and evolution of macular atrophy by division of different, first of all, genotypes of different patients who were in these participants, and whether the geographic atrophy status of the fellow eye also affected the development and progression of macular atrophy over time. And then of course, overall, how many of these patients who have neovascular AMD at the time of initial recruitment did come up or develop macular atrophy over time. So what they saw is that, first of all, of the total number of eyes of 708 eyes, about 204 did develop incident macular atrophy following neovascular AMD. And the mean time to the development of that atrophy was about 3.8 years. And this number, the cumulative risk of developing it really increased with the years of untreated neovascular AMD that was followed up, so that approximately by 8 years of follow-up, 50% did develop macular atrophy. And so, and if you look at the area where the atrophy developed, the central evolving risk of macular atrophy was actually quite high, with about 30% already appearing right at the first appearance of atrophy. So as soon as the atrophy developed, central vision was affected in about a third of all of these patients. So we really see that this is something that really increases with time. And what they also looked at with the stratification, as we spoke about, in terms of whether there was any demographic differences or whether there was any genetic predisposition, showed no difference to the rate nor to the percentage difference of atrophy development in different subgroups. The geographic atrophy in the fellow eye, however, did demonstrate a much higher risk for macular atrophy in the eye that is being treated and followed. And the difference is about 44% at 5 years for those who already had geographic atrophy in the fellow eye versus 26% in those who did not. So really this is, as we said, unprecedented data, because this is obviously now no longer an option for nowadays, because as we know, we treat all patients with neovascular AMD. So I think the data that it generates is really interesting and gives us, you know, I think, as you're saying, debunks sort of the myth that anti-VEGF, you know, perhaps plays a accelerating role in macular atrophy, when we see that the natural history of macular atrophy is actually quite high, even in those patients who just develop neovascular AMD without any treatment. And that really, as we said, by 8 years, 50%, and by 10 years, over 60% of patients will develop it.
Thanks, Cynthia. That was a great overview and succinct presentation on what really was kind of a dense paper. And I think that you pointed out that this paper shows us that geographic atrophy, and more likely macular atrophy, which is how we refer to atrophy in the context of wet macular degeneration, is a process that happens as a natural course of the disease in this very unique patient population that was not treated with anti-VEGF. And so maybe now we can lead into the second paper, which is perhaps more direct evidence as to what role anti-VEGF does or does not play in the creation of macular atrophy.
Great, absolutely. So the second study comes from a different era. This one is also based on a study we all know very well. It's a post-hoc analysis based on spectral domain OCT imaging of the Harbor study. And this one also specifically looks at the progression of macular atrophy in the population of patients who were treated for neovascular AMD, as we know, with ranibizumab, with two different dosage regimens and also different regimens of treatment. And so this paper was also published earlier this year in the Blue Journal by Gune et al. From Vasada's group. And what we see is that what they were able to do is use SDOCT, which, as we know previously, most of the prior imaging and analysis of macular atrophy was based on either color fundus photos with or without the help of adjuvant fluorescein angiography imaging. And so this was the first paper that really used very strict guidelines, which were based on newer criteria for the definition of macular atrophy, which came out of the classification of atrophy meetings papers from 2017 and onward, which gave very clear definitions of terms that we all know, for example, C-aura, RORA, I-aura, and so all these new terms, as we know, macular atrophy is actually a subtype of C-RORA. And by the definition, as per this paper, they were looking for any signs of macular atrophy, which was defined as fulfilling either three criteria. So the presence of hypertransmission to the choroid, measuring a distance of 250 microns or more, loss of RPE for the same amount, 250 microns, and any signs of outer retinal loss. And so if the patient fulfilled all three of those criteria, that was a definite case of macular atrophy. And if there was two criteria fulfilled, this was a possible or probable atrophy. So this was really the first time that such strict imaging criteria based on OCT was used to define the presence of macular atrophy based from the patients of the Harbor cohort. And what they demonstrated was that, first of all, the patients from all four subgroups, so ranibizumab 0.5 monthly, ranibizumab 0.5 PRN, ranibizumab 2 milligrams monthly, and ranibizumab 2 milligram PRN, over the 24-month were reviewed. All the OCTs that were obtained on a monthly basis from all the patients were reviewed. And what they saw was that, first of all, the borders of the atrophy that was measured as per SDOCT differed from, or was more clear cut compared to those that were previously measured using color fundus photo or FA alone, in the sense that sometimes because of blood, of fluid, these might have obscure details of the borders of the lesion, whereas the SDOCT imaging looks at these quite differently. And so what they saw is that, first of all, there was a definite difference already from the outset in the amount of macular atrophy in the four groups, with the ranibizumab 0.5 monthly group having the most amount of macular atrophy at baseline already. However, when they followed these patients month by month through the serial imaging up to month 24, what they found was that the amount of progression of macular atrophy was actually surprisingly no different between the four groups, and was around about 25% overall in all four groups. That was really interesting as a finding, and goes a little bit different or against some of the findings that, the discussions that has generated this discussion that we saw in some of the CAT study findings, as well as some of the prior IVAN study findings, where there was a suggestion from their data that continuous regimen versus PRN did generate or progress towards a higher percentage of macular atrophy at the end of the follow-up period. So I think, this really also generates a lot of interesting discussion. Of course, the two studies that we just mentioned are not comparable due to the difference in the timing of the study, the methods, and the images used for grading the amount of macular atrophy, and also how the treatment was followed, one being observation and the other being active treatment with anti-VEGF. But I think, they point to a lot of good questions, and it's really good food for thought for discussion.
Thanks, Cynthia. Yeah, I think you bring up an excellent point there at the end, which is that, this sheds more light. Will it ever definitively answer the question of whether anti-VEGF therapy plays a role in the formation of macular atrophy? No, because that trial, as you said, is never going to happen, because we'd really have to compare untreated group to a treated group, and that's obviously, that trial is not going to happen. But I think it's great that we discuss these papers that are excellent in their own right, but we discuss them together because they give us the different side of the coin. What happens in an eye that has never received anti-VEGF treatment? Well, we can see that there's still a significant amount of macular atrophy that develops, and so this may just be a natural course of the disease. And if we compare, and then on the other hand, we have eyes that have been treated with anti-VEGF, and contrary to some of the early the 2-year CAT data and the early analysis that was done on the IVAN data, which showed that perhaps more intensive treatment resulted in increased macular atrophy, this post hoc analysis of the Harbor data tells us that that's not really the case, and also demonstrates the necessity, as our diagnostic technologies evolve, to utilize these technologies in better understanding diseases. And we can get into a little bit more later how we each measure macular atrophy and geographic atrophy in our own practices and what imaging modalities we'd use. So with that, we'll take a short break, and when we come back, we'll be joined by the rest of our panel, Christina and Basil, as we take a deeper dive into what this very interesting data means for our day-to-day clinical practice. All right, welcome back to New Retina Radio Journal Club. Joined now, after that excellent discussion by Dr. Cynthia Qian, by my other panelists, Christina Weng and Basil Williams. And so guys, let's talk a little bit about how this data translates into what you thought and what you see. So are you, based on these findings, totally convinced that anti-VEGF treatment has no effect on the formation of macular atrophy? Are you more convinced than you were before? Is the jury still out? So let's go to you, Christina. What do you think?
I definitely find the data reassuring. So from the IVAN, CAT, Harbor, Horizon, there's been a lot of studies that have hinted that there is a correlation between anti-VEGF and macular atrophy. And of course, that all makes us nervous, especially when you're trying to decide between different treatment regimens. With a lot of the data showing us that monthly treatment is very good for visual acuity outcomes, it does make you think twice. But I thought it was, referring to that first study from the ARIDS cohort, I thought that was a very excellent study to learn a lot from, because like you said, we're really leveraging history. We're leveraging a point that we'll never have again, where we can actually watch the natural history of untreated neovascular AMD. So I thought that was very reassuring to see and learn from that just naturally, there's a lot of atrophy that happens without even any sort of intervention. And as you alluded to earlier, when we're talking about macular atrophy, which is distinct from geographic atrophy, we're talking about atrophy following subsequent to neovascular AMD, it really comes from 3 different points, right? You can get it from the natural disease state itself, so you can get it from the neovascular exudate, and you can also get it potentially from anti-VEGF drug treatment. So I thought that study really helped to calm some of the fears in terms of what anti-VEGF might contribute. But like you said, there's always this inkling of, well, maybe there is still some contribution, because we're never going to have, the ideal study where you would have one eye that's treated with wet AMD, the other eye that's not treated with wet AMD, and compare those two. We'll never have that. So, referring to the post hoc analysis of the Harbor study, I thought Cynthia did a great job summarizing that. It's hard to draw from that study that there's no effect. I don't think you can conclude that, because there was no comparator arm. So while we don't see a dose-dependent effect given based on regimen or the dose itself, 0.5 or 2 milligrams, you don't know what necessarily would have happened in the absence of anti-VEGF because that study was looking at ranibizumab treatment. So, there's still this tiny possibility, I think, but I think that the majority of what we see is natural history. I think that there is still a small possibility that anti-VEGF could be contributing, but I felt like these two studies were actually very reassuring. And the other thing that I will say that kind of caught me by surprise was just how shockingly high the incidence and prevalence of macular atrophy are in these populations. I mean, it's much higher than I guess any of us would have thought. And I think that's important to think about in the context of some upcoming treatments, fingers crossed, in the next few years.
Yep. Can't wait for all those combination trials that are likely to come out. But I think you hit it right on the head, and thank you for doing that for our listeners, that macular atrophy, could develop from three sources, as you said. The natural history caused by exudative damage to the RPE, or potentially caused by anti-VEGF. And while this study neither of these studies rules that out, it certainly makes us feel more comfortable that that component is likely small, or certainly much smaller than what may have been hinted at by earlier studies. And just as a point of clarification for our listeners, the CAT trial showed some difference where more frequent dosing led to greater rates of atrophy at 2 years, but that result was not seen at 5 years. So that did not carry through. And IVAN, when they did a revamped, more detailed analysis of their initial data, which had found that, again, that there was a frequency-related formation of macular atrophy with anti-VEGF treatment, they actually, it was refuted. So now we have some more data that seems to point us in the direction that there is not likely or not likely a huge effect from direct anti-VEGF causing macular atrophy. Now, Basil, let me ask you quickly, in lieu of these findings, how does that change your management, or how does that play into how do you treat your macular degeneration patients? Does it make you feel a little bit better about treating them more frequently? Did you previously, before some of this data started coming out, worry about treating them too frequently?
I don't think first, I'd like to thank you for giving me the opportunity to participate. And I would say that when I'm thinking about taking care of patients with neovascular or macular degeneration, I'm more concerned about treating the disease than I am about the development of atrophy. And that's always been the case. I agree with all three of you that have basically stated that these studies are reassuring in a lot of ways. And I think the natural history obviously plays a role. When you're looking at the ARED study, it is possible that because patients that were treated with laser and PDT were excluded, there is some component of the exudative process that's playing a role in the development of macular atrophy. Whereas when you're looking at the Harbor post hoc analysis, there's potentially the element of the anti-VEGF medications that are playing a role. And so it seems like those two might be competing in some ways, where if you're not giving injections, there may be a component of the exudative part there. And if you are giving those injections, maybe that plays a role, but at least you're working on improving or hopefully curing the process of neovascular macular degeneration. And so if the anti-VEGF medications are slightly increasing or if they're slightly increasing the risk of macular atrophy development compared to the natural history, it doesn't seem that it's dose dependent. It doesn't seem that it's treatment style dependent. And so I don't really have a problem treating as much as necessary to take care of the disease. And then, on the other side, if you don't end up treating at all, the exudative process might be playing a role to increase what's going on with the natural history anyway. So you might as well treat the disease the way it should be treated without worrying as much about the role that it plays in macular atrophy development.
Great. Yeah, to add my 2 cents, I think, we'll know more about the actual pathophysiology of this as Sweps horse OCTA becomes a modality that more of us use, because then we'll be able to determine, what does anti-VEGF treatment do to the morphology of these choroidal neovascular membranes. I think we're learning that it doesn't ever really make them go away. And what it does is that it prunes them and takes away the potentially dangerous exudative component of it while maintaining the integrity of that choroidal neovascular membrane, which can then preserve the RPE. And so that's just my 2 cents, my hypothesis as to why I think that anti-VEGF treatment does not cause macular atrophy, but we'll know more as we get more into swept source OCTA. So sort of quick fire before I kick it back to Cynthia for any final comments. Christina, Basil, I'll start with you. Christina, what modality do you use to follow geographic atrophy or macular atrophy?
I think we all get OCTs already, so I think, of course, that's helpful, but I like following with color fundus photography as well as fundus autofluorescence. I think that's a really nice way of tracking borders. But, you know, as you said, I think that's going to become more prevalent. I don't think a lot of us sit there with measurements and really record metrics because there's nothing we can do about that disease state right now. But as we get some promising agents down the line for geographic atrophy, we may start actually, you know, sitting down and taking careful measurements and perhaps following those patients more often as well, since crossed fingers, we may have a treatment to offer these patients finally.
Yeah. Basil, what imaging modality do you use?
Yeah, so I get OCTs regularly. I'll also add autofluorescence from time to time. But as Christina mentioned, I don't necessarily measure the atrophy as often as I probably will when we have an option to do something more about it.
Yeah, great. Yeah, I think all those modalities are great. I personally like OCT because it allows me on the on the C view, on the on-phos view, to really delineate it well and then get more granular on the B scans as to what layers are being affected. So Cynthia, you've heard us babble on here for quite some time. You are sort of the expert on these 2 papers. Any final thoughts on anything you'd like to add?
I think I agree completely with all the points that all 3 of you have made. I think as you're saying, Jorge, as our technology gets better, the imaging modality is going to make, the quantification and characterization even better. And I think, the SDOCT paper is a step in that direction, in the sense that we're trying to really make it a more systematic way of quantifying and measuring these areas so as to be able to follow them better. And, I think what we've seen and in the previous studies is that there's quite a bit of variation at the current time about the percentage of that. And I think part of it is just from, using differing modalities for imaging, different measurement sizes. Does a lesion at 150 microns count, or is it really 175 or 250? So I think as our imaging modalities get more in detail, I think we're going to come up with more consensus about how to best define and how to better see even at a more cellular level.
Yeah. We sound like one of those NBC infomercials, right? Like the more you know. So it's true. The more you know, the better you can treat and manage this disease. So with that, that's actually an excellent segue and a great tease and preview for our upcoming episode, where we will be discussing swept source wide field OCTA in the diagnosis of diabetic retinopathy. I'd like to thank my co-panelists, Christina, Basil, Cynthia. Thanks for joining us today. And to all our listeners, I'd like to remind you that you can download this episode wherever you download podcasts at New Retina Radio Journal Club. And you can also visit the website at itube.net, where you can see our handsome or not so handsome mugs in the case of myself and Basil. And you can also subscribe, and please don't forget to rate us so that we can continue to improve content for you. And with that, we'll be signing off.